Welcome to the Dr. Izzy's Medical Podcast channel.
Hyperprolactinemia. Hyperprolactinemia is the presence of abnormally high levels of prolactin in the blood. Normal levels average to about 13 ml in women, and 5 ml in men, with an upper normal limit of serum prolactin levels being 15 to 25 ml for both. When the fasting levels of prolactin in blood exceed this upper limit, it is then considered hyperprolactinemia. Prolactin is a peptide hormone produced by lactotroph cells in the anterior pituitary gland. Prolactin is involved in lactation after pregnancy and plays a vital role in breast development. Hyperprolactinemia may cause galactorrhea, which is production and spontaneous flow of breast milk, infertility, and disruptions in the normal menstrual period in women, as well as hypogonadism, infertility, and erectile dysfunction in men. Although hyperprolactinemia can result from normal physiological changes during pregnancy and breastfeeding, it can also be caused by other etiologies. For example, high prolactin levels could result from diseases affecting the hypothalamus and pituitary gland. Other organs, such as the liver and kidneys, could affect prolactin clearance and consequently, prolactin levels in the serum. The disruption of prolactin regulation could also be attributed to external sources such as medications. Signs and symptoms. In women, high blood levels of prolactin are typically associated with hypoestrogenism, anovulatory infertility, and changes in menstruation. Menstruation disturbances experienced in women commonly manifests as amenorrhea or oligomenorrhea. In the latter case, irregular menstrual flow may result in abnormally heavy and prolonged bleeding. Women who are not pregnant or nursing may begin producing breast milk, but many premenopausal women who have hyperprolactinemia do not have galactorrhea, and some women who do have galactorrhea do not have hyperprolactinemia. This is due to galactorrhea requiring adequate levels of progesterone or estrogen to prepare the breast tissue. Some women may experience a loss of libido and breast pain, especially when prolactin levels begin to rise for the first time, as the hormone promotes tissue changes in the breast. In men, the most common symptoms of hyperprolactinemia are decreased libido, sexual dysfunction in both male and female, erectile dysfunction, infertility, and gynecomastia. Because men have no reliable indicators such as menstruation to signal a problem, many men with hyperprolactinemia being caused by a pituitary gland tumor may neglect going to the doctor until they have major headaches or have problems caused by the enlarged pituitary tumor. They may not recognize a gradual loss of sexual function or libido. Only after treatment do some men realize they had a problem with sexual function. Because of hypoestrogenism and hypoandrogenism, hyperprolactinemia can lead to increased risk of osteoporosis. Similarly, the presence of hyperprolactinemia in men can lead to hypogonadism and osteolysis. Causes. Prolactin secretion is regulated by both stimulatory and inhibitory mechanisms. Dopamine acts on pituitary lactotroph D2 receptors to inhibit prolactin secretion, while other peptides and hormones, such as thyrotropin-releasing hormone, stimulate prolactin secretion. Due to this, hyperprolactinemia may be caused by disinhibition or excess production. The most common cause of hyperprolactinemia is prolactinoma. A blood serum prolactin level of 1,000 to 5,000 milli-international units per liter could be from either mechanism, but greater than 5,000 milli-international units per liter is likely due to the activity of an adenoma. Macroadenomas have levels of prolactin up to 100,000 milli-international units per liter. Hyperprolactinemia inhibits the secretion of gonadotropin-releasing hormone, GnRH, from the hypothalamus, which in turn inhibits the release of follicle-stimulating hormone and luteinizing hormone from the pituitary gland and results in diminished gonadal sex hormone production. This is the cause of many of the symptoms described below. In many people, elevated prolactin levels remain unexplained and may represent a form of hypothalamic pituitary adrenal axis dysregulation. Physiological causes. Non-pathological causes include ovulation, pregnancy, breastfeeding, chest wall injury, stress-associated REM sleep, and exercise during pregnancy. Prolactin levels can range up to 600 nanograms per milliliter, depending on estrogen concentration. At 6 weeks of birth, estradiol concentration decreases, and prolactin concentration returns to normal even during breastfeeding. Stress-related factors include physical, exercise, hypoglycemia, myocardial infarction, and surgery. Coitus and sleep can also contribute to increased prolactin release. Diagnosis. A doctor will test for prolactin blood levels in women with unexplained milk secretion or irregular menses or infertility, and in men with impaired sexual function and milk secretion. If prolactin level is high, A doctor will rule out other conditions and medications known to raise prolactin secretion. After ruling out other causes and prolactin level remains high, TSH levels are assessed. If TSH levels are elevated, hyperprolactinemia is secondary to hypothyroidism and treated accordingly. If TSH levels are normal, a MRI or CT scan is conducted to assess for any pituitary adenomas. While a plain X-ray of the bones surrounding the pituitary may reveal the presence of a large macroadenoma, the small microadenoma will not be apparent. Magnetic resonance imaging is the most sensitive test for detecting pituitary tumors and determining their size. MRI scans may be repeated periodically to assess tumor progression and the effects of therapy. Computed tomography is another indicator of abnormality in pituitary gland size. It also gives an image of the pituitary, but it is less sensitive than the MRI. In addition to assessing the size of the pituitary tumor, doctors also look for damage to surrounding tissues, and perform tests to assess whether production of other pituitary hormones is normal. Depending on the size of the tumor, the doctor may request an eye exam with measurement of visual fields. However, a high measurement of prolactin may also result from the presence of macroprolactin, or otherwise known as big prolactin or big prolactin, in the serum. Big prolactin occurs when prolactin polymerizes together and combine with Ig to form complexes. Although this can result in high prolactin levels in some assay tests, macroprolactin is biologically inactive and will not cause symptoms typical of hyperprolactinemia. In asymptomatic patients, macroprolactin should be assessed and ruled out. Treatment for hyperprolactinemia is usually dependent upon its cause, ranging from hypothyroidism, drug-induced hyperprolactinemia, hypothalamic disease, idiopathic hyperprolactinemia, macroprolactinemia, or prolactinoma. In order to provide the proper management of hyperprolactinemia, the pathological form and physiological increase in prolactin levels are differentiated. For functional asymptomatic hyperprolactinemia, the preferred treatment is removing the associated cause. Medical therapy is the preferred treatment in prolactinomas. Medications that are dopamine agonists, such as cabergoline and bromocriptine, often preferred when pregnancy is possible, are typically used to decrease prolactin levels and tumor size upon the presence of microadenomas or macroadenomas. Other dopamine agonists that have been used less commonly to suppress prolactin include dihydroergocriptine, ergoloid, lizuride, metergoline, pergolide, quinagolide, and tergeride. Vitex onuse castus extract may be tried in cases of mild hyperprolactinemia. No treatment is required in asymptomatic microprolactinoma, and instead, serial prolactin measurements and pituitary imaging is organized in irregular follow-up appointments.
Thank you for listening Dr. Izzy's medical podcast series. If you want to support this project, please subscribe the channel and like this video. Thank you.